Okay, hello people. Hopefully there are some people tuning in to me live. This is my first attempt at a YouTube live. Well, I've done a few YouTube lives, but this is the first attempt where I'm using streaming software to deliver myself laid over these slides. As you can see, I've set up a fancy green screen behind me. So yeah, a few things. So obviously, please do use the chat function to talk to me, ask questions, etc. But any feedback on how the stream is going, sound, visuals, etc., will be super useful to me moving forwards. First problem I found is I couldn't find how to set it to go live, but we're good. We should be live. Hopefully, everybody who is tuning in before and after will be able to see. So, what I want to do with some of these live streams is to deliver some presentations that I've written usually for in-person events, but they're one-off events, and then they're obviously seen by people at the live event, but then I have these presentations that are left over, and I have nothing really to do with them. So I thought I would deliver some of them onto my YouTube channel and see whether people like that or not. So yeah, tell me whether you like it or not. That's really useful. Hit the like button. I should probably say please subscribe to the channel, and then you will be able to see all the other stuff. Let's talk about knee pain and other key differentials. This is a presentation that I wrote for a knee symposium, orthopedic knee symposium in 2023. And this was talking about, it was predominantly an osteoarthritic event, and so this is a presentation I wrote about some differential diagnoses for people who are presenting with arthritic knee pain. So I will cover a couple of arthropathies, talk about symptomology, and then a little bit about decision making as well. So hopefully that will guide you in decision making with regards to when you have arthropathies and what you might do with them. So we're going to talk about what should we do with those patients once we've made some sort of decision. So the first thing to talk about is complexity, and I quite often like to start with this slide. It's talking about the question osteoarthritis versus rheumatoid arthritis, and I always say it's a bit more complicated than that. So here what I created was this chart, and what this is really showing is the overlap of different symptoms for different arthritic conditions. So in the middle we've got synovitis. The rheumatoid arthritis is predominantly a synovitic disorder, so the inflammatory system is causing a joint synovitis. But as you can see, there is an overlap with a number of other conditions that also cause synovitis, maybe of different joints, but still they're causing a synovitis. So things like psoriatic arthritis, septic arthritis, osteoarthritis, gout, lupus, polymyalgia rheumatica can all present with some features of synovitis as well. So we really need to understand the difficulties related to some of these presentations in that they overlap. We need to be able to reason through some of the differences, but in the end what we are looking for is, do we need to refer this patient for further investigations into rheumatology, or can we hold on to them in musculoskeletal clinics? And that's some of the sort of decision making that we need to make. So if we take rheumatoid arthritis just as an example, then if we purely looked for synovitis as the sign of that condition, then of course we're going to be wrong in a number of cases. Osteoarthritis and gout are much more common than rheumatoid arthritis as an example. Lupus masquerades as rheumatoid arthritis, as can polymyalgia rheumatica. So we need to be able to make sure we understand that distinction. I talk about this slide in a lot more detail in some other presentations, so you can go try and find those. I'm tempted to actually do a live stream where I talk specifically about this slide in some detail. So when we have someone come in with what we consider to be potential arthritic knees, they've not got a clear mechanism of injury, they're probably a bit older, you know, those kind of things. But we're going to think about this patient maybe having an arthritic knee. The first thing we're going to start looking for is, are there features of inflammation? Do we think inflammation is either causing the symptoms or is playing a large part in the symptoms? And of course, that's going to be the same in acute injuries, but at the moment we're talking about this lack of acute injuries in this situation. And key features of inflammation are pain, heat of the joint, redness, and swelling as well. And they're common, and they are common across all drivers of inflammation. So again, if you've got an acute injury, if you've got osteoarthritis, if you've got rheumatoid arthritis, any of those types of arthritis, anywhere where inflammation is causing the issue, an infection, then you are going to see a combination of pain, heat, redness, and swelling. So that doesn't really help us very much. So we need to be able to differentiate out what is going to be a systemic inflammatory disorder. So we're looking at things like rheumatoid arthritis, comparative to a localized inflammatory issue, which is like osteoarthritis, although you could argue that is a low-grade systemic inflammation as well. But key indicators here, and starting to make some differences, are stiffness. So if the patient volunteers that their joints are stiff, then this is a key indicator of an inflammatory arthritis or an acute inflammatory arthritis. So we're going to see stiffness, particularly first thing in the morning, lasting longer than 30 minutes. And a lot of our criteria will actually require 60 minutes of early morning stiffness. We're going to see night pain, and this can be quite specific. So it typically will wake patients in the second half of the night, and they usually have to do something about it. So they have to take some anti-inflammatories, they have to move around, do some exercises, they have to do something to ease the symptoms off. The symptoms tend to be better with activity and not improved by rest. So again, this is a nice distinction between something like osteoarthritis and rheumatoid arthritis. If you have an osteoarthritic knee, that is almost always worse with activity and almost always improved by resting, at least to a degree. Whereas with acute inflammatory disorders, they're typically better with activity and doing things and not improved by rest. And then I'm in the way a little bit here. Let's move me out the way. There we go. Better with anti-inflammatories. Again, a real key indicator with these rheumatology disorders. So we'll see a significant improvement with things like ibuprofen or naproxen, etc. A really strong improvement with those. And the more of these features of the inflammation you can see on this side of the slide here, the more likely it is that this is an acute inflammatory cause or even a systemic inflammatory cause, and the more significant the individual components are as well, the more likely that is. So let's say if we take joint stiffness in osteoarthritis, we're looking at a maximum of about 15 minutes, whereas rheumatoid arthritis, this can last a number of hours, so 2, 3, 4 hours, whereas you're not going to see that in osteoarthritis. So we can distinguish the individual components as well as the number of those components as well. So the next really important part, and this I think probably when I see second opinion patients and when I am teaching, this is where our knowledge falls down a little bit, this is where the understanding of the different systems and how they relate to the different types of arthritis. So we're not just looking at the joint, we are looking at the whole system, the whole person, and how they present and all of their comorbidities together as well. So the musculoskeletal system, certainly as for myself as a physiotherapist, this is what I'm most comfortable with. Bones, joints, ligaments, tendons, really confident, well, like reasonably confident with the musculoskeletal system and when there's a problem with that. So again, you take a joint, you bend the knee, it hurts, likely the musculoskeletal system being involved in some fashion. Now, what we need to make sure we do as well is when we have patients with potential arthritic knee, we need to then understand the other systems that are involved. So, for example, the integumentary system, which is the skin, and this is really important in things like psoriatic arthritis. So typically patients will present with joint pain or tendon pain and psoriasis. So if we think about the normal population, about 0.4 to 0.6% of the population are going to get a psoriatic arthritis, probably about more like 0.4%. But if we look in the psoriasis population, so if you take people with psoriasis, 25% or more, 25 to 33% of those are going to get psoriatic arthritis. So as soon as you see that comorbidity, your suspicion raises up quite significantly. Similarly with the digestive system, so here we have Crohn's disease and ulcerative colitis. These are inflammatory diseases of the bowel and the digestive system, and they have the same sort of numbers. And again, the ocular system, this is uveitis and iritis. These are inflammatory conditions of the eye. Now, they're more likely to be related to the spine, but the multi-joint nature of a lot of these conditions means that you could have spinal pain as well as your arthritic knee pain. So we need to make sure we're asking about psoriasis, Crohn's disease, ulcerative colitis, and acute anterior uveitis or iritis. And we also need to be asking about that as a family history. So let's go back to psoriasis for a second. And the psoriasis population, about 25% of people are going to get psoriatic arthritis. If the person has a family history of psoriasis or psoriatic arthritis, they've got about a 16%. So it's lower than if they've got the psoriasis themselves, but that's still significantly higher than if there is no history of psoriasis. So we need to make sure we ask about these comorbid conditions in the person themselves, but also in their family history. And it's been, I would say, not that uncommon for me where patients go away and I leave them almost with a bit of homework. Go and find out about your family history if that's possible. See whether anybody has any of these conditions. And quite often they'll come back. They'll go, oh, yeah, actually, it turns out my father does have psoriasis. And then you add quite a lot to your suspicion there. So the multi-system involvement, very, very important. So we're going to map that on with our inflammatory symptoms as well. So what about clinical reasoning? So here, this is where we need to start making decisions. There's no hard and fast rules, certainly in rheumatology, as to who definitively we should refer in to further investigate and who we should hold on to. That is, it's a little bit more grey than that. So the way that we're going to build our clinical reasoning process is both the number of things that are present and also the severity of things that are present. The more things and the more severe, the higher our suspicion is going to be. So let's stick with psoriasis. So we've got a patient who comes in with knee pain, insidious onset knee pain, and it turns out that they have quite a strong inflammatory pattern. So what this would be, this is that their morning joint stiffness is lasting an hour and a half, 2 hours. They get very good response to anti-inflammatories, and they are much improved with activity. We then ask them about other joints, and it turns out that they have not only a knee problem, but they also have a foot pain, they also have an elbow pain, and so what we're seeing is this wider spread distribution. So we can, again, go with severity, and it's probably not quite the right description, but it's of the distribution. So if you've got a unilateral symptom, unilateral joints being affected, so just one knee, for example, then you're going to have a lower level of suspicion than if it's bilateral, so if there's both knees being affected. But then the highest level of suspicion is when you're going to have upper and lower limbs affected. So if your knee and your elbow, for example, are affected there, because think about how many conditions can you think of that are going to affect you, a knee or a limb, lower limb and an upper limb? Not that many. Most of them are going to affect either lower limbs. So you start running program, your feet start to hurt. You'd be weird if your thumbs hurt as well. It just doesn't happen. So unless you fall down the stairs, get hit by a car, something like that, you usually are going to see lower limb or upper limb. So you rarely see both. So we're going to consider that distribution as well. So we're mapping on the inflammatory pattern and the distribution. Great. I thought I had a different slide there. So there's my first technical problem of the I thought it said we would have multisystemic issues. Then we're mapping on the multisystemic issues here of the psoriasis. So we have the inflammatory pattern and the distribution, and then we have that comorbid history of the psoriasis skin complaint or skin diagnosis. So we've built that pattern. Now, if we walk that back a little bit and we go, let's reduce the number of things and the severity, that's where the decision becomes a little bit more difficult. So let's say they have a very mild inflammatory pattern. They've got joint stiffness for maybe 15 to 30 minutes first thing in the morning. It is only the one knee that's affected, and they've got a family history of psoriasis. Now, how do we make that? Is that a bond or referral into rheumatology? No, it's not. They don't have the psoriasis. Your suspicion level is raised, but it's only one joint. It depends how the presentation is of the symptoms, but they've got a low inflammatory pattern, they've got a low distribution, and they only have the family history of psoriasis. Now, in that situation, you go, okay, I'm going to manage this patient to a degree, but I'm going to have a low threshold for onward referral. So I'm going to think about, what am I doing with this patient now? I'm going to treat them, but if my treatments aren't working, then I might refer them later, or if new symptoms develop. So if the other joints start to experience issues, or they develop psoriasis or something like that. So something then changes along in the future, and then you change it. And the thing that changes could be time. So think about how long the patient's been with you managing these symptoms. So if you've got a patient that comes in, they've had 3 or 4 weeks of symptoms, I'm not too concerned about it being a systemic inflammatory issue because of those reasons we just talked about. But you treat them for 3 or 4 months and they don't improve. Now the duration of their symptoms is a lot longer, and that might change your clinical reasoning process at that point. So we just need to revisit some of these diagnoses when we do them. So what I want you to be doing is making a note of inflammatory patterns, making a note of comorbid histories, and then returning to them if and when things aren't going well or they're not going as expected. So what to do? What next? This is the real crux of the issue. How do we make that decision? And I think you have 4 options. I think you can refer the patient to rheumatology. So those are going to be your barn door cases, the first kind of thing with, a lot of inflammatory pattern. They've got psoriasis, multiple joints affected. Great. Refer them off to rheumatology. Rheumatology will treat them, and they'll probably do quite well. You don't refer, so you hold on to that patient, you treat them, you manage whatever their symptoms are in the whatever fashion you deem appropriate, and that could be helpful in that second scenario I talked about, where they've got low inflammatory pattern, or if you're confident that it's not a systemic inflammatory disorder. I quite like what I call watchful waiting. So at that point, what I'm doing is I'm noting down these inflammatory components. I'm noting down their comorbidities, but they're not meeting a threshold for me for referring into rheumatology. So what I'm going to do, I'm going to treat them, or I'm going to manage their symptoms, or get someone else to do it who's got a better skill set than I do. But on the proviso that if a specified duration passes and nothing's changed, or new symptoms develop, at that point, I'm going to revisit my differential diagnosis. I'm going to go through that again and see what's occurring and whether we need to change our decision making at that point. I usually will put on a 3-month revisit at that point. I feel like if nothing's changing in 3 months, then we really should be revisiting differential diagnosis. Sometimes it's longer, sometimes it's less. It depends on sort of the patient who's in front of me. The final option, which I really like as well, is the phone a friend option. So I'm going to phone up my colleague or walk next door, speak to my colleague and say, I've got this patient. What do you think? Here are the symptoms. Here's what's been going on. This is my thought process. What do you think? 99 times out of 100, I bet they agree with you. I bet they come to the same conclusion as you, but it gives you that nice bit of reassurance. Occasionally, they might go, oh, have you asked this question? Have you asked that question? Have you thought about this? Actually, I think that does reach a threshold for referring onwards. And sometimes you just get that little bit. So one of 2 things would happen, both of which are positive. 1, you get reassured. 2, you get a bit of an idea that maybe you should refer this patient on, and some clarity in that position. So I really like that option. All of those 4 options have their place with individuals. My least favourite way of people doing it is when they get blinkered to the diagnosis that's made. This person has an osteoarthritic knee. Let's treat it as an osteoarthritic knee. Months and months and months pass. Nothing is changing. They go up through treatment hierarchies, and what's happening is no one's revisiting that differential diagnosis when it is appropriate to do so. And they have these inflammatory components to their disease, and they're not being sort of reconsidered and thought about whether actually that's what's causing causing the symptoms. That's sort of what I don't like to happen, if that makes sense. Okay, so that is the crux of that little presentation. Hopefully you found that of use. Please do put into the chat what you think about the presentation, both from the content point of view, but also the tech Has it worked? Hopefully it has worked, and I've not just been talking into my microphone and there's no one there. So hopefully that's not happened. But please do let me know. Do hit like, do hit subscribe. I'm going to try and do some more of these if I can make sure the tech's nice and stable. I'm going to keep them relatively short. Going to give people more notice that they're going to come up so we can tune in. But yeah, any topics you want me to cover, do put them in the comments as well. I've been Jack, the rheumatology physio. Hopefully I'll see you out some more live streams.